Hi, everyone, and welcome to the latest webinar from Zoe. It's about vaccines and the immunosuppressed. And today I'm joined by Professor Ellie Barnes, who's Professor of Hepatology and Experimental Medicine at the University of Oxford, and Professor Gavin Giovannoni, an academic neurologist based at the Blizzard Institute, Barts, and the London School of Medicine and Dentistry at Queen Mary's in London. I'm Professor Tim Spector. I'm lead scientist on the Zoe COVID study and also Professor of Epidemiology at King's. So thanks to everyone who's submitted their questions. We've got plenty of them. Looking forward to getting some of these answers and discussing the tricky topic of vaccines and immunosuppressed and also reinfections. And with more than 500,000 people in the UK having some compromised immune system, really want to know more about how COVID vaccines are working for them and which drugs we have to worry about, et cetera, et cetera. So we're going to be discussing about how vaccines are working in people with these problems, what alternatives might be considered, what are the various risks and benefits, how long your antibodies are going to be lasting, et cetera. So let's get right to it and let's ask the question, first of all, what do we mean when we say immunocompromised? Who wants to say that? Who wants to answer that one?
Well, I'll give it a go. I mean, immunocompromised just means that your immune system doesn't respond to various stimuli normally. And the regulators like the European Medicine Agency, MHRA, would say that if anybody's got a drop in white cell count or lymphocytes, if they've got at risk of opportunistic infections, if they had blunted vaccine responses, and if they can't sort of survey the peripheral system for tumors, for example, those immune system fights cancers, you're at increased risk of cancers. So I mean, any deficit in the immune system, that can be, you can be born with a deficit, a primary immune deficiency syndrome, which are quite rare, or in response to treatments. We put people on lots of drugs to suppress the immune system to treat different diseases. I'm a neurologist, work on MS, for example. Almost all our drugs we use for multiple sclerosis suppress the immune system. Same would apply to inflammatory bowel disease, rheumatoid arthritis, psoriasis, etc. So I think I would imagine that's probably the biggest chunk of people who've got immune disorders on immune suppressive therapies. And then there's also the cancer patients, people who are having chemotherapy for various cancers, that also knocks the immune system. So almost all oncology patients in a window of time when they had their chemotherapy will be immunocompromised.
And some of the immunotherapy ones in cancer, you sort of need the immune system to react as well, don't you? So it's some of those might be going the other way, who are on those drugs to boost the immune system.
And I would just add to those groups that also patients can be immune suppressed because of their underlying disease. So for some groups of patients, it's not the fact that they're on specific drugs. For example, I look after patients with liver disease and patients with advanced liver disease because of the nature of their liver problem, and that's true also for kidney disease. People with advanced renal disease, because of the nature of their disease, they're also immune suppressed and prone to infection and prone to not responding perfectly to vaccination.
So a question I get asked a lot is, a lot of people, the commonest drug we use, and I used to do a lot of rheumatology and give out low-dose steroids all the time. So low-dose prednisolone, cortisone. People on low doses of this, it's very common. Are they in this category of risk? And is there a smallest dose that, or is it hard to say? Gavin, you?
Yes, so I think low-dose chronic therapy is immunosuppressed. We see blunted vaccine responses in our MS population. People who've had steroids in the last 4 or 5 weeks are much higher risk of getting admitted to hospital and going to ITU, get COVID. I mean, the dose is variable because one of the things we haven't discussed is, and we were discussing it earlier on, is age. As you get older, your immune system begins to work less well. We call that immune senescence. But and so the steroids almost certainly interact with age. So there are a lot of factors that drive into this immune suppression. So I'm very uncomfortable saying what dose is safe, what dose is not safe. I really do, because there are other factors that are involved. I mean, most people talk about anything less than 10 milligrams of prednisone a day as being okay, but I'm not 100% sure we should be giving a definitive dose. What do you think, Ellie?
I think the lower doses are safer for patients in that they have less toxic effects from the steroids. So, you know, their bones are less affected and these other things. But I agree completely, Gabby. And the fact, you know, the reason we keep people on these low doses at all is because they continue to suppress the immune system at a low level. So I don't think we can say any particular dose is safe.
And as we said, they might be masking the disease, that if you took them away, that would also be a problem for the immune system anyway. So we're generally excluding steroid sprays, I presume, for asthma and things like that. Do we think we're not worried about them?
It's not my area of expertise, but there are some people that are on quite high dose spray. So again, I think it's dose, but I think in general, topical steroids are taken out of this equation because they're considered to be very low and only topical, not systemic.
I think a lot of people are worried, but I think generally it's quite different to take it, by injection or by mouth or these sprays which don't have the same systemic effects. Okay, so we're talking about lots of people. I mean, we think what? 500,000 people, that's sort of, it's a lot of people in the population, and as you get older, that proportion goes up as well, doesn't it? So
yeah, if you include the people with chronic diseases, it's more like 17 million people. So actually, if you include all the people with arthritis, kidney, lung, diabetes, liver disease, all of which can affect your immune responses, we're talking a really high percentage of the population. So I think this is a really, really important issue.
Oh, that's a bit scary. Okay, but all right, well, somewhere between the two, then we'll say between 1 and 17 million. And just being immunocompromised, just so before we get on to the vaccines and things, that gives them extra risk of infections. And what else? What are the other problems apart from generalized infections they might get?
Well, they get a higher risk of secondary malignancies, and there's certain types of malignancies that are associated with immune suppression. So it's usually skin first, as it's squamous and basal cell carcinoma in the skin, and then the lymphomas and leukemias come in second. Those are the indicated diseases for immune suppression. So it's that. But I think the real indicator is opportunistic infection. So these are infections that don't normally occur in the normal population that have got a normal immune system. And these are organisms that are odd. They just don't cause infection in normal people. So that's a real signal for immunosuppression, is opportunistic infections.
Right. So people are getting lots of urinary infections, and males getting urinary infections, or in strange places that you wouldn't normally get them. Okay. All right. And we got a question from an anonymous contributor saying, what are the stats for those who are immunocompromised, catch COVID, double jabbed, end up seriously ill? Do we have enough information to give that sort of, that sort of data? I think they're worried about once you get to hospital and you've had these problems, how many people go home and how many people don't. I think it's a sort of worrying question here. I think that's what it is.
Yeah, so Tim, I think we don't have enough data yet, simply because the vaccines haven't been around long enough. I mean, the vaccines only being launched in late December. So, so there has been a lot of data on what happened before the vaccines in terms of poor outcomes. And we know that in my specialty, people with MS are much more likely to get into hospital and get into ITU and die compared to the general population. And those on certain types of immunosuppression are even above that. But I don't think we have enough data yet on vaccine failures. But based on immunology, I suspect we are going to see a signal, simply because the vaccines don't work as well in this population.
Yeah. Okay, so we need to wait and see and collect better data, really. Okay, so let's move on to COVID vaccines in this group. So we know that vaccines are the best way to protect people from serious COVID-19, particularly hospitalizations and death, and estimated we've probably already saved about the same number that have died. It's about 130,000 lives is estimated, and perhaps more than 250,000 hospitalizations. But not most vaccines can be given to almost all individuals, but not the case for some of these with an immune system suppression. So I think the advice has generally been most people are fine. Is there a clear category of people that shouldn't be vaccinated at the moment, or do you think nearly everyone will, which was the previous advice? Are there some people that it's dangerous to vaccinate in the general groups we're seeing, or do you think 99% it's safe?
So, I mean, these are not live vaccines. The vaccines that we're using in the UK are not vaccines that kind of, can replicate or cause infection themselves. I think that's a really important point. So in that regard, they're safe. Whereas other vaccines, we would advise patients on immunosuppressives not to take. That's not the case with COVID vaccines. But I think the key issue is that not everybody will respond to these vaccines. But the advice at the moment is that people on immune suppressive drugs or people that are thought to have immune suppressive diseases should be vaccinated with COVID vaccines.
Yeah, so I agree with you. We took the policy that even if there was a theoretical risk of not responding or a reduced response, some immunity would be better than no immunity. So we advised our patients to get vaccinated as soon as possible. In terms of some timing, Tim, in the MS space, you can actually delay starting treatment by a 3 or 4 week period. It's not like we have to start the treatment today. Some certain diseases, you have to start the treatment today. You can't wait. But so we would then get them vaccinated, and we managed to get permission to give them the 2 doses, 3 or 4 weeks apart, as according to the license, rather than so we could get them back on their treatment. So we actually vaccinated them before we started the immunosuppressants. But that's a small number of patients relative to the total population.
And is the same true for flu vaccine? Then are you generally advising flu vaccines in your patients?
Yeah. Yes, we're actually prioritizing them for flu vaccines. Again, I mean, it's just really important that people get a flu vaccine who have got chronic disease or are immunosuppressed. So
they'll get a milder disease even if they do get it.
Yeah, exactly.
What is quite interesting in some of our immunosuppressants, an immune response to a brand new vaccine is very different to a booster response to a memory to the flu. So a lot of our therapies we're using in the multiple sclerosis, they've tested flu vaccines in the past, and they've shown an increase in titer amount of antibody. But we've seen when we've given them COVID-19, no antibody responses. So there is definitely a difference, and we know there's a difference between a booster memory response versus a brand new novel new antigen, new protein vaccine.
Okay, well, that brings us on to boosters, really. So we've known that they've been given priority for boosters because the antibody response doesn't work as well. So any special information about that? There was a time when they were going to bring forward the boosters in some of these people. Is that what you advise? Or do you have to measure the antibodies first, or do you just guess they haven't had a good response? How does it work in practice?
Well, it's very confusing because I don't know if you're aware, on the 1st of September, the JCVI put out that letter about the 3rd dose. And they were saying the 3rd dose is not a booster dose. It's actually part of the primary vaccine. So it should be given to all immunosuppressed patients in the vulnerable group. And that could be given 2 months, at least 8 weeks or more after the 2nd dose. And that doesn't count as a booster. The general practitioners didn't get that message. So a lot of our patients were approaching us. We're not allowed to give the vaccines. We're referring them to their GPs. The GPs were saying, you're not eligible for the booster because it's too early. So there's been a lot of bad messaging from the government around the 3rd dose versus the booster. And they're quite different, actually. And so what we've been saying is—
explain the difference to people, because—
So what happens is, because you're immunocompromised, and we know that antibody responses may be blunted, the government came out with a recommendation that you should have a 3rd dose of a vaccine as part of your initial vaccine. Whereas most people in the general population have had 2 doses, people that are immunocompromised should have a 3rd dose. And then the booster dose is when you get it 6 months after your 2 or 3 doses. So they're different. The 3rd dose is part of the primary immune response.
But the dose in some countries, the dose is different.
Yep.
But not always, as far as I can work out.
Yeah. So I'm talking about what we do here in England, in the UK. Elisa, have you had any? So the third dose, I've been saying to our patients, it's difficult to time these things in relation to their treatment. They should have it as part of their initial vaccine dose. That's what we've been telling our patients, to go ahead and get their third dose.
So there was this confused messaging, but I think the clear message now is that patients who are immune suppressed or who've got chronic diseases that can cause immune suppression should have three primary vaccines, and then subsequently they can be boosted. And as you say, Gavin, that third primary vaccine should be given as soon as possible to this patient group, not waiting the 6 months. So I think that is a really important point. The government made this recommendations partly because of data that emerged from our national study Octave, where we measured responses to 2 vaccines and showed that approximately 40% of patients generally who are immune suppressed had a low response to 2 primary vaccines, and 10% had no response at all. And it was partly that data that drove this recommendation for this third primary vaccine. And there's emerging data now that patients who didn't respond to 2 vaccines, some patients do respond to a third. I think there's emerging data to show that that's the case.
Yeah, so I think, so that's the key message here is whether you call it a booster or you call it a third vaccine, just have it. Whatever it is, take it, I think it's the...
So the other thing that came out is the third and the booster doses are meant to be the mRNA vaccines, the Pfizer and the Moderna vaccines.
Moderna, yeah.
That's the recommendation we were given.
Is that just because we don't know enough about the other ones, Oxford, AstraZeneca?
I think it's got to do with the antibody responses. When you look at the that is much more effective at inducing antibody responses. Elliot, do you have any more information why that was? Is it because of the antibody response being better with the mRNA vaccines?
Well, there's this issue about giving the Oxford AstraZeneca to younger patients anyway, because of the clotting issue that emerged. That combined, I think, with the higher titers of antibodies that you do see with the mRNA vaccines led to the recommendations that we give an mRNA vaccine, which is Pfizer or Moderna. Yeah.
I can say something as well. There's just been a publication that's come out on the archive. It hasn't been peer reviewed yet, from Norway, where they actually took people in MS on immunosuppressants that hadn't made a good vaccine response, mainly to the Pfizer vaccine. The majority had Pfizer. And they boosted them with the Moderna, and they managed to get quite good antibody responses with a third dose. But they used the Moderna vaccine rather than the Pfizer in those people, and I was quite impressed. They managed to seroconvert most of the patients, well, about half of them to levels. So I think this is really good news. Is the third dose or the booster dose can make a big difference to these people that are immunosuppressed.
Yeah, I don't want to give the message that the Oxford AstraZeneca doesn't give high titers antibodies. So just to say that all these vaccines give very high titers of antibodies against COVID-19, and we still don't know what level. There's no precise level or measurement that we can give to a patient. I'm sure we're going to come on to this, Tim, but there's no precise measurement where we can say you're definitely protected or you're not. That doesn't exist still yet.
Okay, well, I think we've covered that. Is there anything about particular immunosuppressants as opposed to disease that's more likely to be problematic than others? Or do you think it's too complicated to separate them out from the disease and the severity and things?
No, I think there's some clear things to say about this. So one is patients who've had solid organ transplants, where they're on quite profound immunosuppressants with things like, tacrolimus, cyclosporin, plus prednisolone. Those patients may be particularly...
These are liver and kidney transplants we're talking about mainly.
Yeah. And then patients who have received rituximab, or those kind of drugs. Actually, Gavin, you know much more about this than me, but patients who've received specific drugs that deplete your B cells and your antibodies, which means that you specifically can't make an effective antibody response. I think those those patients may be particularly susceptible to making a non-response to vaccines.
Yep, that's exactly the same experience in ours. We got a follow-on drug. There's a couple of follow-on drugs from rituximab, ocrelizumab, ofatumumab, ublituximab, and then there's also a class of drugs in MS, as they call them, the S1P, sphingosine 1-phosphate modulators. Examples there are fingolimod, siponimod, ozanimod, ponesimod. Those also are extremely, I mean, they just blunt. Not only the worrying thing about the S1P is because they trap lymphocytes in lymph nodes and they disrupt the lymph node function. They not only block antibody responses, but they block T cell responses as well. So they look like a class of drug that is also on the careful list. And the other drug that's come out, which is used in solid organ transplant, is mycophenolate. It looks like that's pretty bad to be on in terms of blocking antibody responses.
Mycophenolate, which is used in lupus and other autoimmune conditions. Okay, so there are some drugs, but I guess also the severity of the condition as well is also important, and other health factors come into it, and age. So we've got a question here about, so if you're immunosuppressed, do you need a vaccine if you've already been infected by COVID? I guess is the question, which I can answer a bit, because I don't think there have been sufficient data in these disease subsets. But in the general population, we know that at 6 months, you're getting about 65% protection after a natural infection, which in our data at least is less protection than you get from vaccination with either of the vaccines. And we've got some data which we're going to be presenting more of, that about 1 in 5 people don't actually develop any antibodies after infection, but 80% do, and often that does last for a long time. So it's a bit of a lottery, even for normal people, about whether you're going to get that natural long-term immunity. And I think this is just something to bear in mind, that yes, immunocompromised is more extreme, but even if you are not on these drugs, don't have this disease, there's still a bit of a lottery because everyone's immune system is rather different, and we all react in different ways. But I think the answer to the question there is, if you have a natural infection, whether you're immunocompromised or not, I think getting 3 vaccines afterwards is still going to maximize your chances of avoiding further infections.
There's a very nice data I've seen on this, Tim, has come from Imperial College, where they had a very large cohort of renal dialysis patients. And the renal dialysis patients had to keep coming to hospital in shared taxis in order to have their dialysis 3 times a week, right throughout the height of the pandemic. And because of that, this was a patient population that was particularly exposed. And a large proportion did become infected because of this. And then they were vaccinated. And there's quite a striking difference in the strength of the antibody and the T cell response in patients who were previously infected. So, many patients who were previously infected and then got 2 vaccines made quite a good response to those 2 vaccines, whereas those patients that were not previously infected and then got 2 vaccines made a really poor response. So I think the message is the same as you were given, the more the better in a way. So, the more antigen exposure, and obviously that's much better through a vaccine than through being infected, the more likely you are to boost your responses if you're a patient with kind of chronic disease. Yeah, no,
I think it's even more important in immunocompromised than perhaps, because in the normal population it goes from 65% protection to 95%, but it probably it would be lower in, but a bigger gap between those two.
Yeah, exactly. Yeah.
Okay. Another question here: is there any point in having the booster? Well, it's really the same question. If you've had a poor response, is there any point in having a booster? I guess is the question. Or is this where you should try a different try and get someone to give you a different vaccine?
Well, I think, I mean, we've kind of answered that in the sense that, yes, you should get another vaccine. And if you can get, I mean, the third and booster doses are mRNA. So the people who've had AstraZeneca, I think it's quite difficult if you've had Pfizer to then demand a Moderna and vice versa. So I think a lot of the people who had the mRNA vaccines first will probably get the same one again. But yes, definitely. And there's data now to show this. People who haven't made good responses on the first two are getting the third and making a good response. And Ellie mentioned that as well. So that's the advice, get the third dose.
How easy is it for your patients, either of you, to get antibody levels measured on the NHS, which would seem to be pretty crucial? I mean, we're spending, 20 billion a year on track and trace and dodgy PCR tests, but it is quite hard to get antibodies done.
Yeah, I would agree. So, I mean, at Oxford, where we're clearly a research center, it's relatively easy to obtain that through the hospital. But I'm having other patients that have been contacting me from around the country that have had to go to private providers for this because they don't have a tertiary hospital that can do this for them. And there's specific patient advisory groups actually that are advising patients not to have their antibodies measured, because at the moment it's difficult to interpret how that should affect behavior. What should you do with that result if you have your antibody tested by a private provider or even within a hospital setting at the moment? So I mean, my own personal view is that it would be good to measure this. At least you've got a result. You can talk about it. You can come to a rational decision about how you're going to behave in the light of that. So I think we should be measuring them.
I mean, from someone who used to do masses of tests for my autoimmune disease patients every month, it seems crazy not to have that information to me. Yeah. Gavin, do you agree or not?
No, I agree, but I do exactly what Ellie does. I always ask the patient, knowing that you're positive or negative in terms of seroconversion, how you're going to use that information. And if they're not sure how they're going to use the information, then I would say it's best not to know about it, because, but the problem about tests is when you get the result, it often does change behavior. So somebody who has had 2 vaccines and hasn't seroconverted may be very careful about going to outdoor events and may change their behavior in terms of social distancing. And I think that's the important. They'll treat themselves as being vulnerable. Where they seroconvert, they may be more confident. But again, I keep telling them the fact that they're seropositive doesn't necessarily mean it's going to protect them against the new variants, for example. So we can't, it's no guarantee.
And it's all a question of risk, there's no absolutes. Yeah.
Yes.
Okay. All right. So, and is it easy for your patients to get the NHS antibodies?
We've got them when we requested them. So, but again, we're in a tertiary teaching.
It's not a district general.
No, it's not. Yeah.
Outside London. Yeah. Okay. All right. So I think private tests, they are hard to interpret, but again, I think the advice is if it's going to change your behavior and change your decisions about vaccines or whatever, then probably it's worthwhile knowing about it. Otherwise don't. It might just worry you and confuse you. And certainly, I mean, I've had some problems interpreting some of these antibodies because the companies don't actually reveal very often. They're often yes/no tests, and you don't know the titers or anything, how strong that response is. It's very hard to get the data.
And even when you do know the titer, the range of a positive response is massive. So it can go from, let's just say, 50 units up to 20,000 units. And if you're someone where your response is like 52 compared to someone where your response is 15,000, unless you've got someone to really talk to who understands that assay, you really wouldn't know what that meant. So you do have to be doing these tests in the context of someone that can talk to you about the result.
Yeah. Okay. So, and do you, quick question, someone who's had a third shot, are they going to need another one in 6 months' time? Is this just going to be every 6 months, do you think?
That depends on the virology, to be honest with you. So it depends on how the strains emerge. Some of the evolutionary virologists are telling us that there's not much more mutational activity to happen on the spike protein. I don't know if I agree with them. There's a Boston company that's done AI and modeled the spike protein and says there's about 3 or 4 mutations still to come. So yes, I think Ellie, I think maybe you would agree there potentially will be strain, or variant specific vaccines to come,
Yeah, and I think it will depend on the prevalence of infections in our population. So at the moment in the UK, we've got really high infection rates. Again, it doesn't mean everyone's getting sick, though some people are, but infection rates are very high. In a year's time, let's say infection rates are very, very low, then the stimulus to keep on boosting people when everything's quieted down may fall away to some extent.
Yeah, well, let's hope. But at the moment, it's pretty bad with 1 in 65 people. It's pretty bad here. So definitely everyone gets as much vaccination as people will give you.
Yeah. So there is that group in Singapore that I think it's in Singapore that discovered that epitope, which is a part of the protein that looks like it covers all the coronaviruses. It's based from the original SARS-1 patients. And so, we may eventually get a pan-coronavirus vaccine, which would be fantastic if we did. So that may be one good thing that comes out of this, is we get a vaccine that covers all coronaviruses.
Yeah, and do you think there's going to be a difference in regimes for all these various conditions, or it's going to be ages to sort that out? Will MS and be different to rheumatoid, or kidney transplant?
Yeah, I think they will be. I think as we understand the effects of the specific drugs, it will be different. I mean, it may be that it's not possible, however many vaccines you give, to generate antibodies in some people on specific drugs, and we'll definitely know about that in the next 6 months from some of the national studies that are going on, for example.
Okay. Some quick questions here on alternatives to vaccination, or additions, I guess. So one was, are monoclonal antibodies for someone at high risk or early infection going to be useful? And another question about Ronapreve. Can this be used in immunosuppressed people? And in a way, also these other new treatments, the other antiviral that's just been the first results of, can they be used in immunocompromised?
I'm sure there will be. I mean, this is going to change. I mean, this is going to change the dynamics completely, both the monoclonals and the small molecular antivirals, because what it means is that if you test positive, regardless of your vaccine status, if you're a vulnerable patient, you'll almost certainly get access to those treatments. I reckon the NHS, I mean, I saw in the BMJ a week ago, the NHS has just signed a deal with Roche around Regeneron, which is the two antibodies from Regeneron. And so I don't know how they're going to access them. I've been speaking to colleagues in the United States. They've got a drive-through service. They just go and they literally park their car, they get an injection through the window, and they move off. It's unbelievable. So it's going to change things. Ellie, you might know more about how we're going to get these drugs.
So we are using them at the moment. We're using them in Oxford. We're using them at Birmingham. I was talking to a colleague, Alex Richter, there this morning. They are being given to patients who are hospitalized who are PCR positive, where you can't detect antibodies. So you have to send the antibody test off, and the antibody test comes back negative. And then those patients are eligible through a government scheme in the UK at the moment to have Regeneron. The issue at the moment is that the nurse has to mix these two antibodies together and give them as an injection. So it's not at the moment something you can give in the community, but things are moving that way. And the thing that Tim was just describing, where people drive through and you get a vaccine, that's going to come. So there's a new formulation coming where you can give these monoclonal antibodies as an injection, and I think that will be transformative, because we'll be giving infected patients these kind of monoclonal antibodies in the community, and then we'll be able to scale up to protect people who are immune suppressed at a kind of population level.
Okay, we've got a couple of related questions here, really, about it's Carolyn and James. I think are worried about assessing their risk, particularly if they haven't made antibodies. So apart from doing an antibody test, there's nothing really clinically available we've talked about T cell tests, but they're very research orientated as far as I know. But is there anything else people can do, assess their risk?
Well, I tell them to use the Q-COVID risk calculator to give them an impression of how bad their risk is. So that sometimes shocks people into changing their behavior. So, I mean, you know, I think it's quite helpful as a nudge in terms of changing behavior. And
the other point is, even if a bad antibody score doesn't necessarily mean you're at risk, because we can't measure a lot of the other stuff. So it's a question of risk rather than absolute.
Yeah, and I think change of behavior is a very personal thing that will depend on your personal circumstance and how and if you want to change your behavior. I mean, these are fairly personal decisions. So I think, as physicians, we can give people antibody results, we can explain risks, but actually whether you're going to modify behavior or not and how you're going to do that may be an individual personalized decision based on your personal circumstances. That's my view at the moment.
Okay, well, that really sort of links with our the final topic, which is just a few extra questions about how to stay safe when you are in this vulnerable position. And clearly vaccines have helped us enormously with an extra wall of defense. So we've said, just to reiterate, that really vaccines, booster vaccines, flu vaccines are really crucial if you're in that state. And you can log these into the Zoe app and help us get valuable data on really big populations, which is really useful. But either of you have any other advice there about things we can do with measure? Gavin, you mentioned that app that gives you your risk score. Can you just say where people can get hold of that again?
Well, if you just put, it's the Q-COVID risk calculator. You just put that into a Google search engine, and it's done by Oxford, and you'll find it. And you can, it's basically, you just got to put your demographics in, whether you've got a disease, and it gives you it actually gives you a risk based on population, general population, of what's your chances of dying from COVID-19 if you've got COVID-19.
And what advice do you give your patients generally? I mean, without saying never meet anybody or go out, how do you talk to them and help them through this, without being hermits for the next 2 years?
Yeah, so I mean, exactly. I just tell them that they need to be sensible in terms of social distancing, keep their masks on in closed spaces, or avoid them if they can avoid them. And the general hygiene that's been given. I am telling them, though, they've got to get back to living with this thing, because it's not going away in a hurry, and people can't stay locked up forever. So, and we've seen such enormous mental health problems in our patients, and we don't want to perpetuate that. So, and I'm actually giving them a bit of hope, saying that when these treatments are emerging, these monoclonals and the small molecule antivirals, the actual risk of dying from COVID is going to continue to deteriorate, continue to go down. And I think there comes a point where people have to get back to life and live with it.
Yeah, I mean,
Any final thoughts, Ellie? Yeah.
Yeah, I just think this is a really hard time for people who are immune suppressed. I mean, in a way, because we've got the vaccines, that's released everybody else to mix as they are, and our infection rates are still very high because the vaccines protect you from, becoming seriously ill, but not from infection. And that means that if you're an immune suppressed person in that current environment, it's really difficult for you. And I'm very sympathetic to that. And I would give just the same advice, really. These are personal decisions based on deciding how you need to live your life in that environment in the next 12 months, because this is not going to change. This is not going to change very quickly. So, the easy stuff like wearing masks and not going to nightclubs, that's kind of straightforward. But I think the more difficult decisions about when and how you see your relatives and whether you go shopping, these are hard kind of decisions for patients who are immune suppressed at the moment, I think.
Yeah, and making sure you keep your morale up and your mental health,
and that's very important,
which is vital for your immune system. And just an extra thought I had is, obviously we've found that there's a link between COVID severity and your diet and via your immune system. So I think everyone listening out there really diet quality is really important. Get back some real good food, lots of diversity and plants and things, and look at that again. So we need to wrap up, but I think what we've shown with these, talking about these other diseases, how important these cases are, and COVID has exposed problems in these other conditions that millions of people have that are all related to our immune systems. And we've got over 5 million people struggling to get decent healthcare at the moment, as I'm sure many of you know. And that's why we've been asking permission to expand the Zoe app for illnesses like cancer, heart disease, autoimmune diseases, mental health, etc. Because I think we've seen how we desperately need more information like this and use of these apps, etc. So if you haven't already, do join the Zoe app and consent for these wider uses of the data. It'll be fantastic. Thanks to Ellie and Gavin for joining me today for a fantastic discussion. We could have talked for hours. Thanks to everyone who joined us, submitted questions and logged on. Keep logging on the Zoe COVID study app. We'll be sharing useful links with everyone who wants to know more about this in the documents. Do subscribe to Zoe on YouTube and Facebook for all updates. And thank you to all of you out there. Do stay safe and keep updated.